ಮಾಡಿದ್ರೆ ಈ ಸಿಚುವೇಶನ್ ಬರ್ತಾ ಇರಲಿಲ್ಲ ಕರ್ನಾಟಕಕ್ಕೆ 3500.
We are not able to hear you.
Sir, can you hear me now, sir? Sorry, I was having some issue
Yes, ma'am. No issues.
from my phone, sir. I think we'll begin, sir.
Yes, ma'am. Yes, ma'am. President ma'am has joined, ma'am. Shobha Gudi ma'am has not yet joined. We'll go ahead, ma'am.
Okay, sir. So on behalf of the Karnataka State OBG Society and especially the Imaging Science and Genetics and Fetal Medicine Committee, I'd like to welcome everybody who has logged in today. Our topic for today is redefining ectopic pregnancy, imaging applying the latest consensus lexicon with endoscopic insights. So before we begin, I'd like to request Mr. Arun to play a short prayer song to take the blessings of the Almighty. Thank you, Mr. Arun. And after the Almighty, it is our duty and our privilege to thank and always seek the blessings of our elders, seniors, and stalwarts in their field, all the Kasuga office bearers. So we begin by thanking Chief Patron Dr. M.G. Hiramat sir, the patron Dr. Nagaraj sir, President Ma'am Dr. Rajshri Paladi Madam, past President Dr. Durgadas sir, President-elect Dr. Suman Ma'am, Secretary General Dr. Shobha Ma'am, Honorary Treasurer Dr. Shobha Bembalgi Ma'am, and the EC member North Zone Dr. Ashlata Ma'am. Without these people, their blessings and their constant guidance, any such event will not be possible. So a big thank you from all the juniors and students to them. Before we begin, we request the President Dr. Rajshri Ma'am to speak a few words regarding the topic and her experiences. Thank you, ma'am.
Pranams, good evening, everybody.
Thank you.
On the auspicious day of Guru Purnima, I heartily congratulate the Imaging Science Committee of Kasoga for taking a topic which is so very relevant for all of us in the general practice. As Dr. Raju rightly pointed out, that we need to upgrade and abreast ourselves with the newer concepts of terminologies and diagnostic criteria to help in the early and the better diagnosis of ectopic pregnancy. In today's world, we are moving towards a precision decision making, wherein any amount of erratic, diagnosis is not acceptable to anyone, because for no reason that a woman should be lining up in complications or problem for the reason that the issue was not picked up soon, or was identified, or was diagnosed early. I am so very proud of all my committee chairpersons who are doing such a wonderful job. And this vision of mine to have a webinar on every Wednesday, I must say, that has been consistently being maintained by all the committees, and every time we get good deliverance of the subject. Until now, this is the 13th webinar we are having. I've just completed my 100 days in the office, and I feel very, very accomplished that the team who is with me is so strong that they are taking up every matter, whatever we think upon, so very meticulously. And I must say that Dr. Raju is again conducting an imaging science workshop this coming Sunday, that is on the 2nd of August. So much of work is going on all over the state. And Sarvastri Hitaya, Sarva Samaja Sukhaya, the slogan with which we started, that every woman who is happy will continue to, make the society happy and the country happy at the large. So this is being carried out so very well, because whatever torch we light, it has to be spread across to everybody. And I am so very thankful and grateful. All of you are my teachers as well. I learn from everybody, and as long as we are in the practice and in this profession, we continue to learn and remain a student all through, and keep learning from the masters and who are well accomplished in their subject. And hence, I offer my gratitude to all the gurus here who are taken up this academic passion by profession and doing such a wonderful job. Thank you, Dr. Raju, and thank you, Dr. Nazmi.
Thank you so much, ma'am. Thank you, ma'am.
Thank
Thank
you,
you so
ma'am.
much.
Thank you so
Ma'am,
much.
on this very auspicious day of Guru Purnima, I bow to the Almighty and all my beloved teachers. Cesar, it's okay, ma'am. I'll share my screen. Yeah.
Okay, sir. You take
Yes,
over,
sir.
sir.
Thank
Thank you, sir.
you. Is it seen, ma'am?
Sir, it's loading, sir. Just a minute.
Now?
Yes, sir. It's on, sir.
Um, A very good evening to one and all. At the very onset, with blessings of Almighty on this special occasion of Guru Purnima, it's really a great day for me as well to conduct this webinar in front of my beloved teachers and gurus. I thank the entire Kasoga team, the patrons, and especially the president, ma'am, Dr. Rajashri Paladi, ma'am, for giving us this opportunity. And since last year, we have been continuing these webinars, and now we are having it once in 8 weeks, though. But we are every week we are conducting one or the other webinars from the other committees. So I bring greetings from our imaging committee, from all the members. I should especially thank Rajashri ma'am for giving us this opportunity, and. One word to go ahead. Today, we'll be discussing a very important topic. I know there are sonologists who have joined here with respect to maybe most of them are obstetricians and some radiologists would have been joined. So today, I am going to stress more for the obstetricians here because we will try to see what is that in ultrasound you're going to pick up and how that will be correlated in our operative field. And that is that only not only that, we also will look into a very important topic that of understanding the nomenclatures, what we were using. So today we are going to see something which we have learned already, whether we are right in it. And there are many things we are going to unlearn today so that we may not fall in other areas like that it is not considered no more. So we will go ahead. Thank you, Sazin, for being the master of ceremony. I would request the audience that if you have answers, please type in the chat box. So Cezrin will read out and we will have the discussion at the end. And if you really want to stop in between, you can raise your hands where Arun can help us that you can get into connection. Uh, okay. So today we shall try to see the most important topic that we all encounter because I feel in obstetrics and gynecology there are two things that we gynecologists should not make the patient to wait for long, such that if these two patients come to our OPD or a clinic, we should be able to diagnose them immediately and act upon immediately. Those two things I feel are the ectopic because it can be catastrophic and sometimes disastrous because now if you deal early, it's going to be life saving to the mother. And another is torsion ovary. So torsion ovary, though we may not be able to pick up entire thing in ultrasound, but definitely in ultrasound, if you look for those peculiar signs and also with your clinical examination and clinical acumen, I don't want you to ask the lady or the girl to wait for long or make a roam around, get the diagnosis for other investigations apart from USG. So these two things, I think they are very important in our practice. So as we all know, pregnancy is one of the most joyous thing for both the mother and as well as for the couple, as well as for the obstetrician. I would like to hear some answers from you for in this case where I'm trying to show you here is, see, before I would begin, invariably for ectopic gestation, the answer and for the early pregnancy, the answer is always TVS. So I will be concentrating only on TVS because TVS is one which is going to give you enough of information. And also the we have seen in our earlier webinars where it was taken by Dr. Varun Thakur, he stressed upon that all the guidelines which we look into dating scans are all based on our transvaginal sonography only. So the consensus is that better we stick that we have to date the pregnancies by transvaginal sonography only. Okay. So now in this case, I would like to share something. This lady who came with UPT positive, you treated her for her fertility issues, and now she has come with a UPT kit showing that it is positive. And when you put the transvaginal probe inside, you are able to appreciate a intrauterine pregnancy with an embryo within and cardiac activity and a yolk sac. So this is where you feel so happy that you have treated her and now she has come with this UPT positive, and at the same time you look this beautiful intrauterine pregnancy and you show her on screen and you tell her and congratulate her. So now what I want to ask you is that what we do, most of us, is that we put the probe inside, we look into the imaging perspective with respect to uterus, and then we come out. How many of you think that I am right here to remove the probe out and tell her the good news and ask her to come at NT scan? So most of us, we try to do this. So we'll see in our further slides how that we need to do a systemic scan for any intrauterine pregnancy, or whenever the UPT is positive. Okay. So now I want you to answer, how many of you find the differences in this two cases of a case where there are early pregnancies, early intrauterine, to answer them as early, if I want to call them as early pregnancies. So what differences do you find this considered to be the first clip, and this is going to be the second clip? Any change you would like to see? I will give you one more history. Both are previous LSCS cases. Is there anything wrong in either of this? Or both are okay for me to pass on that I have seen an intrauterine pregnancy with the embryo within and a cardiac activity for that in that embryo.
So people are answering in the chat box that the second one is implanted at the scar site. There are a couple of answers, so they've answered.
Okay, good, very good. So my job is very easy. Now I want you to answer these things. How many of you think this is an angular pregnancy or an ectopic pregnancy or anything else? Or how many of you want to say this as a normal pregnancy or an angular pregnancy? You can type the answers, whatever you see. You can mention saying that the image 1 shows what type of pregnancy, image 2 shows what type of pregnancy, and image 3 shows what type of pregnancy. You can
So
take your time.
Yes, a
Yeah.
lot of people are answering first one as normal, sir. Some have written eccentric and angular as well. And then the second one people are saying is interstitial. So some people are calling the first one angular, some people are calling the first one normal as well. Sorry, angular and normal for the first one. Second one, everybody's calling it either cornual or interstitial. And second one, the final one, people are calling it in one horn of a separate uterus.
Oh, very good. Yeah, I loved this. I'm Arun, please can you help me? There is some window which is opening up on my screen. It is asking me to please remove this window. Ah, yeah. No, I'm not able to remove that.
Which one, sir? No, sir. I can't see any window right here.
Sir, but it is showing on my screen. Please remove this window away from the shared application when I opened up the chat box.
Okay. No, sir.
No, sir. Okay.
Hmm?
So, no, it is. I will just stop sharing and then come back.
Yes, sir. Because on my screen it's not this. Right now,
Okay.
madam, do you see anything?
Yeah, now it is not there. Yeah,
So
thank you.
Okay.
So today I would like to stress upon this very important consensus that we got in 2020, almost 2 years back. It was released in last year, 2025, maybe in January, where the American people came up with this Society of Radiologists in Ultrasound, that is SRU, where eight societies came together and tried to bring out some very good consensus so that what are the terminologies that we need to bring about in case of early pregnancies, and also the confusions that we have in making an ectopic pregnancies. So you can take this QR code to download this. It's very easily available. So it was not only one society which came forward. It was around a consensus between amongst the eight societies, including the radiologists, the reproductive medicine, the ACOG, and the other societies of the US. And they made a Delphi consensus where they agreed to almost 80% of the consensus. So now why we need this new lexicon or because see the terms used in medical record were undefined, inconsistently applied or interpreted differently by radiologists, clinicians and patients. And there, there were legal issues with respect to insurance also in US where they didn't want to use, they didn't like to use the word failure uh, or viable, which carries unintended emotional weight, and they wanted to have a compassionate terminologies for all this. So that was how we try to understand. Now the goal was to bring about a clear and scientifically based terminologies which is acceptable across all disciplines and minimize bias and harm to the patients. So you can when the European when the American comes up, the Europeans also had come up via and the Eshrei people way back in 2022. They also tried to bring out good terminologies, and especially with related to ectopics, they also made consensus. You can read both the papers, and here is the newer one in 2026 in January. We got this paper where it has clubbed both together, and they have given a comprehensive literature about ectopics especially, and also you can read this for knowing more about the management of ectopics. So we know the favorite author we have Davor here, who is one of the known personalities in gynec imaging. So definitely this is one of the very good papers that you can read. So now we all know what is ectopic pregnancy. We thought that ectopic pregnancy was an implantation of pregnancy outside the uterus, but it is no more now because they say ectopic pregnancy is an implantation in an abnormal location. It can be within the uterus and it can also be in the definitely it can be outside the uterus, that is extra uterine, or it can also be within the uterus. From MBBS days, we all know the most common site of ectopics are the tubal ectopics that comprises the highest percentage. The rarer ones are the ovarian and also the abdominal, which are very rare. So now, because of the incidence of the cesareans or the insult to the uterus itself, we are now able to see lot many cesarean scar ectopic pregnancies. I'll come to that terminologies. Previously, it was now many people still use the word cesarean pregnancy, cesarean scar pregnancy. Now they want to use the word cesarean scar ectopic. Both the consensus, that is the European, that is ESHRE, as well as the SRU from the American group, wants to use us saying that it is an ectopic. Why? Because it comes at a cost. You monitor it a lot, and it can be associated lot more of the time. It is associated with mortality, not sorry, morbidity most of the times to the mother. Very rarely mortality as well. So even the cervical pregnancy, which we used to term them, now we have to call it as cervical ectopic pregnancy, and also with the incidence of ART procedures and to the insult of the endometrium, the procedures that we do. Sometimes we might also come across something what is called as intramural ectopic pregnancy. So we are there can be a clubbed entity, a normal utopic pregnancy, whereas a intrauterine pregnancy is the term used by the American people, where the Asian people wants to call it as utopic pregnancy. So now we have something what is called as heterotopic pregnancy, where there is coexistence of the intrauterine as well as the ectopic pregnancy. It can happen within the uterus itself or uterus and extrauterine. So here is a lady who comes with UPT positive, and we tried to screen across the uterus, and we couldn't find any signs of pregnancy within the uterus. There was no appreciation of any gestational sac-like lesion, but in the adnexa, we were able to see that there are two cystic lesions in the adnexa, more occupying in the ovarian echoes within. But as we move our probe up down, then we are able to see in this case a gestation sac. Okay, and you do find an yolk sac over here, and you do find an embryo within. So now I want you to answer this. What would be your reporting for this case? So now you are able to appreciate that there is a gestational sac with an embryo with a feeble cardiac activity, which is seen. And how do you report this in your just one short line if you want to say? Ma'am, Cesarin, are my videos playing without any breaks, ma'am?
Yes, sir. Videos are smooth, sir. No issues.
Yes, ma'am. Thank you, ma'am. Previously, we had this issue.
Mm.
So if you are given a chance to report this, I'll give you that it was in the right adnexa. I looked at I spanned across the adnexa and I could find an ectopic pregnancy. And how do you report this with an embryo with a cardiac activity? So now what is the importance here is that now no more you can call this as a live ectopic pregnancy. The word live they don't want to use, because that is where the legal issues have come across, and also the terminologies. This cannot live along. So they say this, you can mention this as an ectopic pregnancy, which is having an embryo with a cardiac activity. That is how we need to term this or put it on paper. So now most of the times what happens is, now when once you have one in early pregnancy, when you have spanned across the uterus and you don't find any intrauterine pregnancy signs like gestation sac like or a probable gestational sac, then you go into that next and try to look. What most of us what we try to do is that we usually go into the planes of ovary. And how many of you think that what I'm trying to look here is this an ectopic pregnancy? So you try to assess here, I'm trying to able to see a cystic lesion well in the vicinity of the ovarian cortex here, and then it is just oscillating out from the ovary. So this can be a confusion to most of us, that we think that it is an ectopic, but it is not, because it is a corpus luteum. And what we do, most of us, is we look at the ovary, we look at the corpus luteum, and then we come across the we come back to the uterus and then go to the other ovary and then remove a probe. Actually, that is wrong. What we need to do is that ectopics usually are the tubal ectopics, as we all know. They are not usually seen in the plane of ovaries. That is what I want to stress. See, only when you do your up-down movements and you should go beyond the ovaries, then you might find a lesion which is in close approximation to the ovary, and this is more echogenic over here. UPT was positive, that is why I have taken for the scan over here, and you can see a good corpus luteum and a tubal ring-like structure that is seen in the adnexa in close vicinity to the ovary. So this looks more like an ectopic gestational sac-like lesion, or a probable gestational sac which is ectopic pregnancy. So what is that we need to do when once you know that it is more likely to be an ectopic? We try to do the sliding sign. Place your probe in between the ovary and the probable gestational of ectopic gestation, and then try to do the sliding sign. See, in very early pregnancy, when you don't find the catastrophic event of having significant bleed and all, you will be able to appreciate a small tubal ring-like structure which is seen, and that is sliding against the ovary. Then the diagnosis of ectopic pregnancy is most likely over here. So we do put color for everything, as we all discussed in gynec scans, and even in the adnexa. I try to put color in everybody, but you may not get good information in differentiating between a corpus luteum and ectopic, because both can have a ring of fire appearance. So now, if I ask you which of this is a ectopic gestation, you are able to appreciate one cystic lesion on this side and another cystic lesion which is showing other characteristics on this side. So start looking at the corpus luteum, because once you start knowing what is a corpus luteum, then definitely you will not miss an ectopic. So now how to differentiate between these two? See, corpus luteum usually it is located within the ovarian echoes, and you find the walls may be thick and the internals may be cremated, and sometimes you might find uh, uh, the strands of the fibrin within. So it might be anechoic or irregular fiber strands that you can see, that is more likely to be an corpus luteum. Whereas an ectopic will always have a thick echogenic rim around, which corresponds to the trophoblastic tissue that you have in this ectopic, and also which is more likely to help me is that the yolk sac that is seen within. Then sometimes you might also find an embryo within. So okay, once you put color, both of them do have a tubal ring-like structure where there's no the ring of fire-like appearance on both sides. So this may not give you much value, or it will not add any value to most of your diagnosis. So what I want to stress upon here in the sonographic findings is that anything which is seen apart from the ovary or in the adnexa, you can call it as an adnexal mass. But if ovary is seen, you call this as an extra ovarian mass. So better terminologies would be better use the word tubal ring, or you can also call as an adnexal ring-like structure or an adnexal gestational sac, which is appearing with characteristic appearance of hyperechoic rim around and all. Sometimes there may be internal bleed within, which will be more echogenic, that which I showed in the previous slide. So when you don't find an intrauterine pregnancy, definitely when the puberty is positive, then more likelihood of tubal pregnancy has to be thought, because that is the most common thing that you find, most common ectopic that we have. So now the important thing is that we should stop using these terms, the Bagel sign, the blob sign, donut sign. This is what they are trying to emphasize. We need not use these words now. We need to be more specific in our terminologies, like start using the words like tubal ring, adnexal ring, or adnexal gestational sac. So that is the important take home message today. And another important thing is that whenever you don't find an intrauterine pregnancy, definitely you should think of an tubal ectopic. That is the first common thing, most common thing that we can have. So let's see how to differentiate between the tubal ring and the corpus luteum. We already seen, just to show that the tubal ring is more echogenic. The tubal ring is more echogenic in comparison to the corpus luteum. And also when you look at the color Doppler, it may not add much of value because both may show ring of vascularity around. Next is the claw sign. Sometimes you might get confused, where the corpus luteum is just protruding out, or it is seen oscillating from the ovarian cortex. Then that is where you have to look around the echoes of the ovary surrounding it, at least for at least more than half of it. Then it appears to be more of a ovarian echo, and usually it doesn't slide against the ovary. That is where you look for the sliding sign. Any lesion which seems to be an ectopic, we'll always try to lesion move separately from the ovary, and that supports your early or your ectopic pregnancy. There is a catch over here. In very early pregnancy, if you find, see, there could have been many ectopics in the general population. Some of them would have had very early tubal abortion or failure. Okay, or pregnant. Instead of the word used, you took out to pregnancy loss. So that is when if it is in very early, and if it is it's not going to continue with, we may not find all these signs. But if it is going to stay for a long time, then again the sliding sign may be negative in some cases because of the inflammation that it can create between the ovary and the gestational sac-like lesion or the tubal ring-like structure that you see. So sliding sign definitely in the early pregnancies can play a very important role to get your diagnosis of ectopic. So location, definitely when it's separated from the ovary, strong possibilities of having an ectopic pregnancy. So now here's a lady who came to your clinic, and she's sitting outside at the waiting room, and suddenly she collapses, just to say that she had giddiness and all, and her UPT was positive. She wanted to confirm a pregnancy, and this is what you see. Because now in an emergency, don't try to do TAS, always go for TVS, unless otherwise proved. Ectopic has to be for such emergency situations. You have to do always TVS. Here you are able to appreciate. I don't want to characterize the lesion that you see. It is the low intensity echoes that you see. It's nothing but the blood and associated clots that you see. Most likely the answer is definitely a ruptured tubal ectopic. So Macfadden's always say, sometimes it is difficult, where one of the authors from British says that looking for an ectopic is looking for a black cat in the night. It can really be difficult to locate that, as sometimes that black cat itself pouches out on you with ruptures like this. So what is the light that you have to show to look that for that black cat is the ultrasound over here. So now these cases are very easy, because I am very sure that none of us will miss this, because when you find low intensity echoes, and when you have a significant amount of fluid in the adnexa, especially in the POD and also in above the planes of the uterus, compared to the last scan, this patient had more significant fluid only in the POD and not in the adnexa. But as I go and approach the ovarian echoes, this is where I located the extra, that is the corpus luteum. I'm not going to stop here, because I have to locate which side is the ectopic. So now probable diagnosis is ectopic, and now I have got beyond the ovaries, and this is where I'm trying to see a gestational sac in the tubal structure, where you find clots within, and it is and associated the blood which is seen around. So most of the times we may not be able to tell exactly whether it is a ruptured tubal ectopic or a tubal ectopic in process of abortion. So when this was likely to be a tubal process in abortion, because it was it was more situated on the ampullary end, and this was in the verge of abortion. And we all know what we try to do in endoscopy, which turns out to be the gold standard for your ectopic management, where you will be able to not only assess the condition proper within, and also you will take the same definitive route of managing these cases by the various methodologies like salpingectomy or salpingotomy. So yet another case to show, sometimes, UPT is positive. This is a axis deviated uterus. I'm trying to see the coronal plane of the endometrial cavity over here, but at the same time, I'm trying to look here, anechoic space like anechoic lesion within the uterus. Most of the times we get this. And do I want to stop here and say that this is looking like a gestational sac or a probable gestational sac? See, if you look here, this is not very regular, and you don't find that proper decidual sign that you get it in a normal probable gestational sac. Definitely, you have to look around the adnexa, have located the corpus luteum, and you can find there is bleed, or there is in the adnexa, you are able to appreciate there are clots noted on the right side, and also the tube is having mixed echogenic structures within, and also you find and gestational sac within. So this is a case where you find definitely that beyond the ovaries I have gone, and I'm able to appreciate heterogeneous mass like lesion, and UPT was positive. And inside inside the uterus, I couldn't define it as a intrauterine pregnancy or a gestational sac. This was the ectopic pregnancy. This was the ectopic gestation that I'm trying to see, or the ectopic pregnancy that I'm trying to see in the adnexa. So I have made the diagnosis of ectopic. So now, what do you call this? What do you call this? Previously, we used to call this as pseudo sac, which has to be abandoned now. They want to call this as intracavitatory fluid. So pseudo gestational sac is no more in nomenclature. So, but also this definitely helps whenever you find a intracavitary fluid and UPT is positive. That gives us a hint that am I dealing with an ectopic? You should go beyond the ovaries to look for uh, the answers. So that was an ectopic. In this case, it was in the verge of tubal abortion. There was no significant bleed that we could also see in the ultrasound. And this was where, one of the modalities of managing a tubal ectopic is by doing the milking. Also, we have to explain the risk that there can be possibilities of recurrent tubal ectopics in the same tube, but only after consent. If we see that yes, we can save the tube. This is one of the modalities which has even been shown in the recent guidelines, that we can go ahead with the milking of the tubal ectopics. So many cases to show, but we all know how to diagnose a case of ectopic. So this was a case. Again, when you find significant hemoperitoneum, sometimes you may not see, it may not be correlating with the LMP. So just 5 weeks, do you find so much of, usually early pregnancy may not show such kind of catastrophe. They would have got the periods when they would have missed the period. I mean to say, the important thing is to ask for the history. How was your last LMP? How was your cycle? Whether it was regular like the previous ones, or whether she had spotting. So that is when we will try to appreciate that we not always depend on LMP. So this lady had the same thing of hemoperitoneum with respect to features of tubal abortion. That same thing in the ampullary region, and in endoscopy route we can use the methodology of saving the tubes. This lady who presented to us for fertility issues, she came with her husband on day 2 of her LMP. And this is when I put the scope for, after she has given her basic routine tests for her fertility profile and all, for the husband has given for semen analysis. And later she got into the scan room. And this is when I put the probe, and she tells she's on day 2 of her LMP. So what do I see? This is the bladder which is over here. I try to, we all know the orientation. I try to keep the bladder near to the logo over here, and the uterus on this side. So this is a bladder. I'm trying to play with the gains such that I'm trying to assess what kind of fluid is this. So this appears to be blood because it is low intensity here. So I went across the adnexa and tried to see, there you have an heterogeneous mass lesion which is closely abutting onto the left ovary. So stop here and ask her immediately, how was your cycle in this period? She told the cycle, I got it early this time, and also it was only spotting for yesterday. So I had pain abdomen since day before yesterday. So here comes the role of asking a proper history. Don't ever go with the LMP, because we all know most of them will tell that I had because it could be because of the area stella which are the associated reaction, and that they could have shred a little bit, and that could have they would have taken it as her menstrual menses. So we may go wrong. So this lady who came for fertility assessment, and you got to know that she has conceived, and now it was a tubal ectopic on the verge of abortion. So ectopic pregnancies behave erratic. That is the reason why we have to tell that whenever you find a lady with suspicion, or if she is having pain abdomen, and if she looks her clinical profile is not good to correlate, always think of ectopic. We always intend to have a normal pregnancy that is different. Okay, now I will give you a very good history of this lady. This lady was our IVF patient, and we did her embryo transfer, and she presented with UPT positive, and her beta HCG was showing good value of around 1200. And when the intrauterine, we couldn't make out any probable gestational sac. So we called her saying that it could, because maybe it could have been twins. So we told her that we will review her after 5 days, after 7 days. Sorry, so it was after 5 days. So it so happened that she came after 3 days, and she came with pain abdomen. I put the scope probe inside, and let me tell you one more history. She was a case of bilateral tubal ectopics, and for that both the tubes were removed in her. So the answer for her fertility issues, definitely it's going to be IVF. So she doesn't have her tubes at all. So now I should expect what I should always accept when it is an IVF done. I expect that it has to be intrauterine. But what has happened here? There was significant hemoperitoneum in the adnexa. Then what has happened in her? So she has come with pain abdomen, and this is where we are trying. I was trying to locate for whether I could see, and there's a clear cut history that she had bilateral salpingectomy. What could be the answer for this? I'll try to show you. We took her to the OT, and just to see this, look at the hemoperitoneum she had. She had torrential bleed within by the time we took to OT from the scan room. And anybody with the answer now? No, both the tubes are not there, and she is bleeding from this end. So what type of ectopic pregnancy is this?
People are answering, sir, stump ectopic, corneal ectopic.
Yeah. So we don't use the word corneal now. This is actually the stump ectopic. So stump ectopic, this is where it can be an our cause of iatrogenic cause, because if you have not removed the tube in its entirety, you may end up having this stump ectopic, which was managed eventually. So I'll try to show you. I got it from net, where I missed looking of an ectopic pregnancy like this in the adnexa, because I had never had a thought that she will have a pregnancy like this. And this was the stump ectopic, which you can have and in the verge of abortion here. This is a internet pic just to give for diagrammatic representation for the stump ectopic. So I am thankful to Dr. Sandesh Khade and Priyanka ma'am for giving me this, because I don't have this pregnancy of ovarian pregnancy, where they are trying to locate the gestational sac within the ovary, and also the corpus luteum was seen within the ovary. And in laparoscopy, what do you find? This is the right ovary. You could find it. It is the pregnancy is located within. Why I am saying this is a ovarian pregnancy? Because it fulfills all the criterias, that the attachments are intact, and it is seen well within the ovary. And also, and once you remove the mass lesion from the ovary, you are able to appreciate the fetal pole and the yolk sac. That confirms that this is nothing but an ovarian ectopic. So these are all the three criteria that we need to look for to confirm the ovarian ectopic. Why am I trying to? I'm thankful to them, because this is a very neat case to show that it is a case of ovarian pregnancy. Most of the times we do often come across reports saying that as ovarian pregnancy, but we intraoperative, most of the times they will be tubal ectopics. So what is the importance here is that whenever you want to bring really good example of an ovarian ectopic, make sure that within the ovary you try to see the corpus luteum as well as the gestational sac in the same ovarian echoes. That is when you can definitely make a diagnosis. If this ruptures, then it would be difficult for us to say that it would have been ovarian. But sometimes we tubal ectopic also because because of the vicinity of the tubal ectopic in close to the ovary, we sometimes make this as ovarian ectopic. That is wrong actually. So how many this was the case I'm trying to show you, where you are able to appreciate the gestational sac is located at one of the angles at the upper cornu. Okay, this is a retroverted uterus. So I'm trying to show in the transverse plane, that is, it is located in one of the cornu or one of the angles of the endometrium, and that is what we call now this as. Actually, we should call this now as an intrauterine pregnancy itself, because you find a good dream of endometrium around, and this is where you look for the serosal borders. So this is now termed as intrauterine pregnancy, which is eccentrically located. So you can term this as eccentrically located intrauterine pregnancy. So go across this paper, because it is going to tell us what we have to use. See, eccentrically located gestational sac, what we have to avoid using the word no more cornual, no more angular, or no more eccentric pregnancies. So this is the importance of looking into the lexicon here now today. So definitely when you try to, this was yet another case of eccentrically located intrauterine pregnancy, because within few days I was able to appreciate that it was moving more into the, don't be of the anxiety that this looks like more of an ectopic. Follow up these cases, they usually do good. So it is no more an ectopic. Now, what is that I'm trying to show in this case? Most of you have answered this, so I will just brush up here, because your answers were perfect. That many of you have told it as interstitial ectopic. Why do I say that? See, pregnancy which is implanted within the intramyometrial segment of the fallopian tube. This is the serosal border, and this is the endometrial border, and it is outside the endometrium but well within the uterine counter. So it is located in the intramyometrial segment of the tube, and thin band of myometrium can be appreciated between the gestational sac and the borders of the endometrium. In 2D, you might also find, I'll try to show that, but I was not able to get that in this case. If you find an interstitial line sign, that is rare, but turns out to be specific, 3D can definitely help us. So we all are correct. It is interstitial ectopic pregnancy. It is no more a cornal pregnancy now. So avoid using the word cornal ectopic. So the same case, when we try to do it in 2D, this is the endometrial line. As it was abruptly stopping at one area, you find immediately following that, you find an gestational sac. Why do I call this as gestational sac? Because you have an yolk sac within, and also a embryo with a feeble cardiac activity within. See, if you don't find an yolk sac or a embryo, then it is not called as an intrauterine pregnancy. It has to be termed as a probable gestational sac. So they have made it very clear. Sometimes in early pregnancy, you get only the gestational sac like lesion without an embryo. So that could be a probable intrauterine pregnancy, but you should not confer saying that it is an intrauterine pregnancy till you find an embryo within. So this is the so it definitely differs from this pregnancy, where you find the end. This is well within the endometrial counters of this. So this is no. It is not an angular now. It is got to be called as intrauterine pregnancy, which is eccentrically located. So the interstitial pregnancies in intraoperative can look like this. So this is how, sometimes if you don't manage them early, they can have a catastrophic event like this, because the most notorious could be this amongst the ectopic. One of those would be the cornal ectopics, because this can, if you are not able to deal it early, then you might end up having a very bad state of hypovolemic shock. So I will skip this, because this interstitial ectopic pregnancy eventually resolved by medical management. That is a rare entity. So now how many of you want to answer this case, where I'm trying to show you a embryo with a cardiac activity, and what you are trying to locate here, what type of pregnancy is this? It is easy for all of you to answer this, because now I'm trying to concentrate at this area. So that is the role of doing an early pregnancy scan, that to TVS, will give us more definitive answers that I'm dealing with the cesarean pregnancy. Now I want you to listen to this and tell me who is the author here. Most of you would have heard to him, listen to him, sorry. So you tell me who is the person who's
No matter what you hear, read, and think, regardless of its management, cesarean scar pregnancy is a very, very, very dangerous kind of pregnancy. I want to also emphasize that scar pregnancy is not an ectopic pregnancy, at least not to a strict
any
definition.
answers?
It is in the uterine cavity. It is embedded on the scar or in
So
the
someone has
previous
answered. It's Timor
previous
Trish.
delivery. And unless true ectopic
Yes.
pregnancy, it
Okay. Yeah, the person here, it is his voice. It is Timor Stitch, Ilan Timor Stitch.
it's a man-made disease. Its incidence is placed between 1 in 2,000, 2,500
So
deliveries, but lately many articles have the impression that
why am I trying to place his talk over here is that the reason is he has done an extensive work in the in cesarean scar pregnancies, and he was one of the earliest authors to have given the sonographic criteria as well, and the cesarean scar pregnancy registry was after him, and also we owe a lot to him because he was one of the first pioneers who has emphasized a lot on doing transvaginal sonography. So that is what about Timor Stritch, and he didn't want to he don't want to call this as an ectopic because he says that it is well within the uterine borders. So he answers this saying that it is well within the uterine borders, and you can also have a viable pregnancy where you can have a potential. It has the potential to survive, while the ectopic does not. So, but the consensus are now different. They are now trying to have a debate between this. I don't want to get into your terminologies. You can keep it as CSP, but what the ESHRE people and what the newer American people, they have come up with consensus and recommendations saying that because of this pregnancy has a potential for significant maternal morbidity and mortality, and this is associated with it. So that is why we need to call this as an ectopic pregnancy. Definitely, because even I was using the word CSP, and maybe I will try to report it as cesarean scar ectopic, but that is what we want to follow a standard terminology across. Because definitely, as an obstetrician, we all know it comes at a cost. We are at anxiety, we are at even the mother, we need a lot of monitoring for them, and the complications are more, and that is why it has its own answers for that. We all know that is why it has to be termed as an ectopic. So we all know how do they present. Most of the times they are asymptomatic. And early pregnancy, they can have PV bleed or low abdominal pain. And if you really miss it, you can and also have a morbidly adherent placenta. So what are the sonographic criteria? What I'm trying to do here in the TVS is the answer for your early diagnosis of CSP. See what all those guidelines, all the sonographic criteria that we have are all based on TVS. Definitely, you can make an answer on TAS, but TVS plays a very important role in your diagnosis. This is the cervical canal over here, which is empty. The upper corpus is empty. You find an now I call this as an ectopic pregnancy with an embryo within a cardiac activity which is situated near to the scar. So what are the criteria? They put it in, you can put it as empty uterine cavity and endocervix. The gestational sac, the placenta is, the residue of the placenta is embedded in the lower uterine segment of the scar area. Initially, it looks triangular, and then if it goes along the upper corpus, it becomes oblong, and that is where you also find the myometrial thickness is less. And definitely when there is trophoblastic tissue, it has got attached at this area, it is very near to the high resistant vessels, and that is where you find increased vascularity. And definitely the answer for all our ectopic pregnancies, always try to look where they are located. So there are many classifications. I don't want to get in all of those because most of you cause science and all those are the early papers. But now the recent one is what the Delphi consensus has come out of this paper. They have made it as type 1, 2, and 3. What they are trying to make out is that they have drawn a line on the anterior border of the endometrial line and the serosal borders, and anything you have a cesarean scar defect over here, and related to that, if you have a pregnancy which is more onto the endometrial count, more onto the endometrial cavity and less into the scar area where you find the decidua or the placenta anchored at that level, it is type 1. Then if it more situated deeper into this plane, then it is type 2, or if it is getting bulged over the serosal plane and encroaching into the adnexa or into the bladder area or crossing the serosal line, it is type 3. So I would like to come to this important sonographic step that we need to do is that I would agree most of you are not only sonologists, some of you will be doing endoscopy work here. And if you look into the Caesarean scar defect or isthmocele, most of them are not situated exactly in the mid-sagittal plane. They are usually located in one of the angles. I would say either the right angle or the left angle. So that is the importance of doing your transverse sweeps in an ectopic pregnancy, or that is the Caesarean scar pregnancy, is very important because sometimes in a sagittal plane, you may not be able to see the proper gestational sac, or you might wrongly measure the RMT. In fact, because we all know the niche is in one angle. These are the uterines, and this is in the transverse plane. This is the bladder. So this is the Caesarean scar defect area. The gestational sac gets embedded within one of the angles. So that is where you need to measure the RMT. RMT should not always be measured in this. It's not always the dictum that you have to measure in the sagittal plane. So this was the same question I asked in one of the webinars to Timur himself, and he did agree that yes, RMT, it's not always in the sagittal plane. So if you do across your sagittal sweeps in the early pregnancy, then you will be able to make out what type of Caesarean scar pregnancies. It may grade up from type 1 to type 2, definitely. So I follow this. It is a very simpler and easy one given by Ilan Timur and his group. It was one of the first classifications. They want to keep it very simple. Look here, this is a scar area with fibrosis. If at all the pregnancy or the trophoblastic tissue is attached at the scar area, which is anchored at the scar area with good myometrial thickness, you want to call it as it is implanted on the scar, or type 1, or it also called as endophytic variety. Why do they call endophytic? It goes in the endocavity. The pregnancy eventually grows more towards the upper corpus, so it is endophytic. So now, if you have a larger niche and if you find a scar pregnancy which has got embedded more deeper planes with less residual myometrial thickness, the trophoblastic tissue invades more into these deeper planes, and this is where you have something what is called in the niche variety or exophytic or type 2. So this is what we need to understand, that to I will try to play some few videos. Listen to this.
So then you get your blastocyst and it comes down and it goes whoop right into the cesarean scar, and that would be a cesarean scar pregnancy, that's a cesarean scar pregnancy, and that's a cesarean scar pregnancy. However, if you're a little bit higher, that's just low-lying, and if you're a little bit lower, that's a cervical isthmus pregnancy. So cesarean scar pregnancies are right in the niche.
Okay, I would like to bring out some basic pathophysiology over here. In a case of a normal pregnancy, when you find a good myometrial thickness, that is where you find both the basal and the spiral arteries. When the decidua gets attached at this plane, you find the trophoblastic invasion of these vessels will make the high resistant vessels to be low resistance, and eventually you have a good perfusion of the trophoblastic tissue. So this is within a normal pregnancy. What happens in ectopic, cesarean ectopic? Usually you have an isthmocele or the myometrial defect, and when the gestational sac embeds, it goes in close approximation to the high resistant vessels, that is the radial and arcuate vessels. This is where because of the high resistant vessels, they are going to have effect on this growing placenta, and that is when you find those lacunae and other placenta accreta associated spectrum in these cases. So you will be in a very familiar situation. This would have been happened to most of you, especially the obstetrician, that you have taken up a case for DNC under anesthesia or whatever it is, and it was an early pregnancy, and you find her that she starts pouring. There is torrential bleed. What could have happened? In the case of previous LSS, this would have been a misdiagnosed case of CSP was taken without any preparedness, and that is where you end up having such kind of catastrophe. What would be the reason is, when you try to do DNC, you are going to actually hitting these larger vessels which are high resistant vessels, there's going to be more bleed. And at the same time, when you don't find a good, this is the area where there is less contraction of the myometal fibers, because you itself don't have the good myometal fibers. So there is less contraction, and eventually these vessels don't stop. That is how, this is one of the analogy given by the author. Look here. Yeah, I'll make you listen to this. It's okay. See, if it is a normal invasion of the trophoblastic tissues, the spiral arteries, you have good flow, low resistant vessels. Then it's like a dog and drinking its water from the tap. But if the invasion goes more deeper into the larger vessels, this is what happens. So these are the initial pathophysiological changes that you can find. This will eventually lead to formation of lacunae and more trophoblastic invasions into deeper planes. That is the early sign of having a placenta accreta spectrum. Consequences, we all know what can a cesarean scar pregnancy can have, and it can lead to. I want you to listen to this very good clip. I don't know why it is not playing.
Well, this is a slide that was shared with me by Dr. Timur again, and it shows you what I now think you would look at and you say, ha, that gestational sac at 6 weeks is too low in the uterus. You can see the decidua implanted in the niche. This is definitely a niche pregnancy, right? But the patient says, it's taken me a long time to conceive this pregnancy. I don't want to give up. I feel fine. I'm not having any bleeding. Can't you see me next week? So she comes back at 7 weeks. And what do you see? Well, the embryo is growing into the gestational sac. It has a good heartbeat. Things are moving into the uterus. And she says, well, look, things are looking better. Can I come back at 9 weeks? So you have her come back at 9 weeks. And the embryo is growing even further into the uterus. It looks really normal, has a great heartbeat. Should we be relieved? Should we feel that, whew, escape that? Anybody feel okay about this? Well, we can't, right? We need to still be worried, because where's the decidua? The decidua is still in the cesarean scar, and the placental vessels are stayed there in this patient as it increased risk for placenta accreta spectrum and the outcomes that I shared with you previously.
Yeah, this is what we are trying to listen in this video, and it's
Well, this is a
very
slide
common
that was
situation,
shared with me.
very common
Well, this
situation
is a
that we all have. See, if you miss an early cesarean scar pregnancy, if it is on the scar variety at 9 to 11 weeks, you would always think that you can get a pregnancy which is moving on to the upper corpus, and that if you do only TAS, it is very likely situation that we are going to miss the cesarean scar pregnancy, not the cesarean scar ectopic. And the importance of doing TVS in any importance of doing TVS in a case of in previous LSS is because we are not just looking at the embryo or the cardiac activity. We have to also look at the site of placenta or the decuda which has got attached, so where it has anchored. So we don't want surprises like this, because I've already showed you that this ESP itself is one of the misdiagnoses that we can can happen and can lead to placenta accreta spectrum. So this was the second clip I played, and majority of you, almost all of you, have answered it. So if I would not have given you a hint, definitely see the placenta is looking in the posterior aspect. Why do you say so? And why? And it usually should be in the anterior, right? So now what is the importance here is that is why that is the importance of looking into the sweeps onto the angles of the scar. Here the placenta, though it looks in the posterior aspect in mid sagittal, it is actually onto the one side, that is more onto the right side. So the niche was onto the right or the left. In this case, I don't know exactly, but the placenta was more onto the lateral aspect, and it has got anchored at the scar area. That is the importance of doing TVS, so that you will be able to appreciate how the scar is related with respect to the placenta, or the placenta related with respect to the scar. So this was the case with embryo, the same case with embryo cardiac activity, just to show that all cases need not always be managed by laparotomy or endoscopy. This case was managed by Dr. Jayaprakash Patil sir here by doing the vaginal approach. Because this is one of the best routes you can choose when if you are a vaginal surgeon, and especially in a low resource setting, and you know that this is an advanced gestation, like if it is around 10 weeks or around 9 weeks, and doing a DNC would have been would be catastrophic, but choosing this approach will definitely help you better. Why? Because you have seen that when sir has separated the vesicovaginal fascia, we have removed the trophoblastic tissue and the ectopic that is there in its entirety and freshened the edges in the same sitting, and also we can repair the defect of isthmocele or whatever the scar defect in the same sitting. This is where a vaginal approach can definitely help. Yet another case to show this is by Dr. Ashish Kubde sir. Most of you, all of you know him. He sir is from Nagpur. So here you are able to appreciate him in an cesarean scar ectopic pregnancy. He has chosen the vaginal approach and he's showing the steps of how to do this. See, you always go with your sharp dissections in any of the planes, even for bladder, you don't even have to separate the bladder over here. It's just the vesicovaginal fascia that you need to separate. And this hue of brownish hue that you're seeing, this is the area of your scar. This is the area of your cesarean scar pregnancy. And once you are separated with your sharp dissections, and definitely you can see here the scar pregnancy, which can be evacuated by vaginal approach itself. And the other advantage of this surgery is that you can also repair the isthmocele defect in the same sitting by freshening up the edges and giving a good outcome for this lady, so preventing the future complications if at all they are there. So yes, vaginal approach can be chosen in a low resource setting, and if you are a vaginal surgeon doing vaginal hysterectomies easily, you can follow these steps to definitely deal with an ectopic, that is cesarean scar ectopic. Yeah, you can very early pregnancy. You can manage this by using endoscopy route, that is hysteroscope. Here, as we entered into the cervical canal and just passed through the internal os, we could see this is at the just in the upper cervical canal. As we pass through the cervical canal, internal os, these are the white jelly-like things. What you see, these are the chorionic villi that you see of the ectopic that is there located in the scar area. So how do we define that? You can also bring out the definition properly, because if you go past beyond it, you will be able to appreciate the normal looking endometrial cavity beyond it. So this was this was definitely located in the scar area, and that was the definition of a cesarean scar ectopic. See, here also this was located more onto one corner, I mean to say one angle of the scar. So early pregnancies can definitely deal with hysteroscopy, where you may or you may not need to use the current or the energy source. Just a loop of the of the electrode can be used to evacuate this. So the most definitive and the most practical approach, if you are an expertise, would be a laparoscope, because here, when you have diagnosed the case of ectopic, and if you are an expertise with your endoscopic procedures, laparoscopy definitely plays a very important role, because you can not only find out the pathology proper, and also you can deal with the adhesions and other adnexal pathologies if at all you have in the same sitting, and the same sitting. After evacuation of the ectopic or dealing with the ectopic, you can freshen up the edges and then do the defect repair in the same setting. So this is the approach of laparoscopy here. Once we have evacuated the ectopic pregnancy in the same sitting, after freshening up the edges, you can definitely repair in the same sitting, so that you are not going to create another defect over here. Okay, such cases are difficult, when you have a plastered or anchored uterus to the anterior abdominal wall. With this procedure, this can be difficult by your vaginal approach. Definitely the endoscopy plays a very important role in these cases. So where after you have dissected out the anterior wall adhesions, and you can deal with the ectopic pregnancy in the same sitting, and the scar area which was repaired. So I have a case to show here. It was a patient was known to us, and at 6 weeks he presented to us. Look at the location of the gestational sac. Why do I call this as gestational sac? Yolk sac is seen, definitely it is a gestational sac, and the embryo was seen with cardiac activity, but the location was at the level of previous scar. The upper corpus was empty. Sorry, the only yolk sac was seen, and we followed up this case and significant vascularity at that area. And I kept following this lady to just to say how this progresses. We counseled her for termination, but she was so adamant. She told that I just want to continue this. I showed you the video prior. I have taken a lot of pains to become to get at this level. I want just to continue. Though the family members were involved, saying the consequences of that, we counseled them, and she was so adamant. She wanted to continue. Now you know where the placenta is attached. It's very obvious that it is cesarean scar pregnancy. I followed her up at NT scan as well. I was finding out the initial changes of formations of this loss of these regularities at the basal, the bladder zone, few lacunae or the anechoic spaces that were appearing. I knew that this case was going for more for a placenta creta now in the future. So this was around at 13 weeks, 3 days, and after 2 weeks, around 16 weeks, these are the early signs of our placenta accreta spectrum that we see in cesarean scar pregnancy. So at 16th week, when she was in the hospital itself, she collapsed, saying with collapse on when she was working, and this is where we rushed her to the hospital. We knew this could have been a catastrophe because it was a ruptured scar ectopic. So what would be your plan of action when you find such kind of huge hemopuritinemia? So we have chosen here endoscopy, the route, because it depends on the expertise who's gone ahead with the sir has gone ahead with the endoscope. Definitely, you can choose any other routes like laparotomy would have been even preferable for those who are in safe hands. So look at the gestational sac. It is a ruptured area, and where is the fundus? The fundus has got actually buried so much of hemopuritinemia there. It was more than 2 liters, and you are able to appreciate the fundus was not at all seen now, and only after doing a lot of suctioning, and this is where we got the fundus, and then we had to evacuate a lot of blood that was there in the pelvis, and we went ahead with the uterine artery ligations on either side. We know 16-week uterus and significant vascularity in the adnexa as well, and altered anatomy sometimes makes it difficult for the surgeon to really get there. But with safe hands, definitely we can reach there with good anatomical knowledge. We tackled the uterines on either side and proceeded ahead with the laparoscopic approach of managing this scar, the cesarean scar pregnancy or ruptured cesarean scar pregnancy. So you are able to appreciate there, the once we have done that, we have separated the bladder, and this is the fetus. So this fetus was mm, removed from the scar area, and we then in the same sitting we removed. So this is the any other video of the Dr. Jayaprakash Patil sir doing wedge resection for the placenta accreta in the term pregnancy as well. It is just like a shorter version of that. You don't find so much of invasion here because it's early pregnancy. So we removed the we did a wedge resection of all those affected the site of placenta attachment, and then repaired in the same sitting. So the fetus was removed by the colpotomy route. So this fetus was removed by the colpotomy route. So these are very rare. I don't say that we can always, if you're not an expert, we need to not go for this route. You can definitely go for the laparotomy route. But what was important here in this case was the uterus was saved in this case, and few about the blood transfusion that was done. Obviously, I followed her up after 6 months. I was very curious to know how the uterus is and what would have been the area of the scar. Luckily, this is the scar area of the same patient now. It has healed well, and also there were no anterior-uterine wall adhesions as well in this case. So, this lady now she is 20 weeks. She has come with pregnancy again. We never expected, and now the placenta is far away from the scar. The placenta is posterior now. Yeah, that is the importance of doing TVS in almost all your scans, and especially in your previous LSCS. Locate the placenta and try to look for the relationship with this scar. So, do you think this is a cesarean scar pregnancy? So 12 weeks, the lower segment would not have been formed. Definitely, it is far away, and this is not an ectopic pregnancy. So, what is the answer for this case? It's not a case of previous LSCS. You are able to appreciate a gestational sac. Why do I call gestational sac? Because there is a yolk sac within, and you find the echogenic rim around, and it is located within. Any answers? I know I have taken a lot of time, but I don't want to miss this. There are few more slides, just few more slides.
Yes, sir. People are answering, sir. Cervical. Almost five,
Yeah,
6 people have answered, sir.
yeah, it is cervical. Why? Because now you got to know, see, the upper corpus is empty and also the internal os is closed and the pregnancy is located well within the cervical canal. So it is cervical pregnancy. So sliding signs can definitely help. See, we would have, in the initial sweep, we would have thought this could have been cervical pregnancy, but looking at there are other areas. Look at the internal loss. It is open, and also doing the sliding. That sliding sign, the pressure on the anterior lip of cervix is making the trophoblastic tissue or the gestational sac to protrude out. So this sign can be definitely used when you are in a confusion to say whether it is a cervical pregnancy in process of abortion or pregnancy cervical ectopic pregnancy failure in process. Okay, that is where sliding signs do play a very important role, and this plays also a very important role in your scarred uterus. So this lady was told to be a cesarean scar pregnancy and they referred to her that she is bleeding heavily. So what did I do here? I'm trying to place my probe in the anterior fornix and trying to do the sliding sign. You are able to appreciate though you find a gestational sac with an embryo, no cardiac activity, but this is in the verge of process of abortion. The reason here is when I'm trying to put the pressure, this sac is getting elongated, and also it is making its position. It's there is change in position of this gestational sac. If this would have been an ectopic, cervical ectopic, that would this probe movement would not move, or it would be anchored, so you don't find these signs. And another important sign is that look here, you have the telltale sign or the comet sign that you find, because this itself tells me that there are clots in the upper corpus, and that is how it is in the process of abortion. So it was actually not a case of cesarean scar pregnancy. The first slide which I tried to show you, already most of you would have got an answer in the back of your mind, that it is always very important that just locating the intrauterine pregnancy and telling the good news to the mother is not the end of the story. You have to do a complete sweep across your adnexa, because in this case, I just showed the short clip there. Just as I moved my probe to look into the adnexa after locating an intrauterine pregnancy onto the right lateral aspect, as I moved my probe, I could see yet another gestational sac just closely abutting the serosal border of the uterus. And what do you want to call this now? This is definitely a gestational sac, because you find an embryo and a cardiac activity within, and also an intrauterine pregnancy. So this is termed to be called as heterotropic pregnancy. So what is the management in such cases? Definitely endoscopy plays a very important role. I cannot keep quiet now, because this can cause a catastrophe, because and it is very close to the serosal borders of the uterus, likely to be an early interstitial, not interstitial part, early isthmic part. So this was the intraoperative picture of the same case, intrauterine pregnancy within, and in the laparoscope, the adnexa on the right side is showing the tube, which has just begun from the uterus. So this is a case of early isthmic part, uh, tubal ectopic. So we injected vasopressin and we proceeded ahead with the management of this case. We just did salpingostomy, and and this is how it was managed. So we didn't do exactly that is salpingectomy here, because it was in close approximation to the serosal borders. So that was fast in and fast out, and with the good management of this case, eventually she went up to term and she delivered the intrauterine pregnancy. So this pregnancy, most of you have answered it right. Now, no more calling it as cornal pregnancy. Previously, it was told to be that it is in one horn. Even when the unicornate uterus was used, a pregnancy in a rudimentary horn was called to be a corneal ectopic and all. It is no more now. You have to define the Mullerian anomaly and then tell where is the pregnancy. So they're telling us to describe the location of gestational sac in what Mullerian anomaly it is. For example, in this case, it is a gestational sac which is located in the left horn of a septate uterus. It's not bicornate because I look at the roof of the house. This is maintaining its integrity. The serosal borders are maintaining. So this is a case of septate uterus. No more don't use the word unicornate pregnancy or bicornate pregnancy. This lady presented with pain abdomen, anything, always a suspicion of ectopic. When you put this probe inside, you find a lot of hemoperitoneum with clots within. There's no time to do for UPT. What do you think this could have been? Yes, by the time you prepare and shifted the OT, UPT was done and UPT was negative. And what could be the reason? These are the differential diagnoses you can also have very rarely in case of a corpus luteal cyst hemorrhage. So this lady had a left ovarian corpus luteal cyst hemorrhage with significant hemoperitoneum that was eventually managed. So for all the postgraduates over here, then if you have a positive beta HCG, always do a transvaginal sonography to confirm the pregnancy. And if the gestational sac is located, or if you find it as an intrauterine pregnancy, then you manage accordingly and look whether it is a probable or a definitive intrauterine pregnancy and manage accordingly. That is intrauterine pregnancy, normal thing. If you don't find a gestational sac or a gestational sac like lesion in the no signs of pregnancy in the uterus, then definitely you have to look in the adnexa, whether if it is located in the abnormal location, and you have to define them wherever they are located, whether it is tubal or ovarian or interstitial. If it is in the uterus, it is interstitial, cervical, or a cesarean scar ectopic. And if at all you don't find any of these answers, if the beta HCG is still positive, okay, then you can call it as pregnancy of unknown location. Yeah, but still you have to always follow up with beta HCG because most of the times it would be a tubal ectopic pregnancies. So what are the important things I want to highlight from the lexicon is that the old definition pregnancy was located in the outside the uterine cavity is now replaced that the ectopic can a pregnancy implanted in any abnormal location is an ectopic. It can be intrauterine and extrauterine. And what are the terms that we need to avoid is try to avoid these terms. Cesarean scar pregnancy, I don't know, some of you can still use, but better would be cesarean scar ectopic, cervical ectopic. Corneal is no more, avoid using it. It can be an interstitial ectopic. Look for that. Live, living, or viable is to replaced by ectopic pregnancy with cardiac activity. According to the American group, live pregnancy is still in vogue with respect to the X-ray people. There is interchange. You can use that because X-ray wants to use the live pregnancy, whereas the American lexicon, what I have shared with you, they don't want to use this word because of. Okay. Last slide, just few slides to end up. So stop using these words, blob and biggle and all. Instead of use the words tubal or adnexal ring, pseudosac is no more to be used. It has to be termed as intracavitatory fluid. And obviously the corneal ectopic, there's nothing like corneal ectopic. Okay. Okay, read this paper. And pregnancy failure is a term that we need to modify. Failure is not the word to be used. Early pregnancy loss is one which you can use. That is better to be used. And at the same time, use it for if it is concerning for early pregnancy loss, or if it is diagnostic of pregnancy loss, or whether it is in progress or whether it is incomplete or complete. So that's about early pregnancy loss. There's nothing like blighted ovum now. It has to be termed as an embryonic pregnancy. There's nothing like nothing like viable pregnancy scan and all. So it's look for early pregnancy scan. So non-viable diagnostic of early pregnancy loss, tubal miscarriage. You should call this as failing ectopic pregnancy. There's nothing like chronic ectopic now. It is residual ectopic pregnancy. Okay, so I thank my boss, Dr. Jayaprakash Patil sir here for all that I am today. And on Guru Purnima day, I wish him, I take his pranams. I take his blessings. Thank you. Thank you, everyone. Any questions, ma'am?
Thank you so much, sir.
Yeah, Raju.
Am I
Yes, ma'am.
Sir, there's a question first. Role of methotrexate in the management of early scar pregnancy.
Ma'am, obviously, if you look into, I have not added this in the literature. If you look into the recent literature which has come out by the cesarean scar pregnancy registry itself, saying that there is very limited role because it is not going to be a definitive approach for your methotrexate. See what you when you have diagnosed the case of cesarean scar pregnancy, and if you are giving methotrexate, yes, if it is very early when the trophoblastic tissue activity is lost, yes, it can stay back as a residual ectopic there, and eventually that has to be managed, or sometimes it get resolved or get resolved. So methotrexate is not the preferable choice now, though it was one of the best choices in the early a few when Timor Stitch himself had emphasized that in the early in the early decades now, but now the recent evidence say best is always go for a definitive approach. Either best is go for a, if it is a on the scar variety, even an ultrasound guided DNC would definitely help, or any other definitive management like hysteroscopic approach or a lap or a vaginal approach would be much better. I preferably
Raju,
don't want to give.
sometimes, yeah, in this niche pregnancies, no, combined approach is good. Like,
Yes, ma'am. Combined,
yeah.
yes, in the initial, when you want to buy time, then definitely no, looking into our
Mm.
blood profile, and then a single dose of methotrexate can definitely help.
Correct. When it is towards the cavity, then under ultrasound guidance, a hysteroscopy can help us,
Yes,
and
ma'am.
it is possible to do. And many people have reported. We have also done on couple of occasions, and it comes out okay. And patients do kind of resolve, after some
Yeah,
bleeding, and then they resolve. And
yes,
in those which are little deeper, then laparoscope can be used as a guide from above, and then you can do so. Hysteroscopic procedure to look at and then gently take it out, with an ovum forceps or very gentle suctioning can be
yes,
done
ma'am.
with ultrasound guidance. For a deeper one, you can use a laparoscopic guidance for the same hysteroscopic approach.
Yes, ma'am.
Because
That is why.
anytime you
Uh,
can convert, you can take over the procedure through the laparoscope like that. And even
yeah,
if this is not possible, then we open and do. So these are the ways. And Raju, I
yeah, that
just
is.
wanted to know, correct?
Yes, ma'am.
Mm.
Yes,
Wanted
ma'am.
to know about cervical pregnancy. If you have kind of a good experience on that,
No,
can
ma'am.
you relate one or two cases of cervical pregnancy?
No, the advanced cervical pregnancy we have not come across, ma'am. Maybe JP sir would have been the best person. What I have
No,
seen was
early only
very
I'm
early,
talking
ma'am,
about,
very
whatever
early. The
early.
say
Mm.
case which I showed, we just managed it by hysteroscope itself. It was too early. It was just around 5 weeks,
Mm.
because only yolk sac was seen, and we instilled vasopressin in the cervical lips, and then we proceeded ahead, and the loop electrode was enough for us to evacuate that. And
Mm.
if at all you find some more of bleed within that, short balloon, balloon pressure would be enough for us to
Correct.
keep it.
Balloon therapy has been
Yeah. Yes, ma'am.
reported very widely for this.
Yes, ma'am. Balloon definitely helps. Even for most of us, ma'am, I would tell now. I showed one case of a cesarean, mismanaged cesarean scar pregnancy,
Mm.
because when the consultant is not knowing, and if
Mm.
you hit a larger vessel and you find lot torrential bleed, you not have to panic. The best thing you do is put up Foley's and then inflate it such that the pressure itself is going to act as a gradient against
Mm.
the vessels,
Bakri balloon
and it
is
will
very
stop.
good for this,
Yes,
correct?
ma'am. Even a Foley's bulb, because sometimes you not be able to
Yes.
inflate such a
Mm.
large Bakri
Mm.
balloon, and you can refer her, you call somebody for help.
Correct. Mm.
And when we find
To
an
there are
cesarean,
some some reporting about two balloons, no?
yes, ma'am,
Two
yeah,
balloons, like
Timor has
what they
even
use for
devised that.
induction of labor, like that
Yes,
one for the lower
two
segment
balloons,
and
one
one
for
for
the
the
yes,
scar
ma'am,
and
one,
one for
one
the
at the scar
cervix.
area,
Yeah.
and one at the
Mm.
intrauterine. Yeah, yes,
Mm.
ma'am. That also was
Mm.
used, but off late it is not so in vogue, ma'am, because yeah, definitive approach would be better
No,
for.
post procedure bleeding I'm talking about. I'm not talking about,
Okay. Yes, ma'am. Yes, ma'am.
though
Correct. Double
though
balloon
even
catheters. Yes, ma'am.
primary procedure also it has been described, and one such paper was published in Yogi also, where they
Yes,
have
ma'am.
used for cervical pregnancy, and balloon therapy, and they have succeeded. So like that, even for niche pregnancy, they have succeeded with the balloon therapy. Okay, so these are, I'm very sure, very early cases.
Yes.
I'm sorry for that.
Yes, ma'am. Yes, ma'am. I got it, ma'am.
And before, I think you must continue the interaction for some more time, but I would prefer to excuse myself. But before that, has Dr. Rajesh already joined?
Madam
Ma'am
had joined in
joined
the
initially.
initial part, ma'am.
Well,
She
I
took
just
up the.
wanted to compliment you very highly, Raju, and
Thank
for your teaching ability. And I'm sure today many of your followers must be wishing you happy Guru Purnima.
Happy
Uh,
Guru Purnima to you, ma'am. Thank you so much,
yes,
ma'am.
thank you. And may you grow with this. A lot of skill transfer is happening in your sessions. All the very best and keep up the good work. Thank you
Thank you
very
so much,
much.
ma'am.
Thank
Thank you,
you.
Thank you,
ma'am.
ma'am.
Thank you so much, ma'am.
So we'll proceed with the questions.
Yes, ma'am.
There are few more, sir. I'll try to club them. So one person has doubt, by cervical ectopic, do you mean endocervical canal or cervical parenchyma?
It is invading into the cervical parenchyma, of course. The trophoblastic invasion. That is what I know, ma'am. I really look. I need to really look into it.
Mhm.
But I because the trophoblastic invasion will be more into the parenchyma only.
Mhm. Right, sir. Another person is asking, by methotrexate, do you mean intramuscular or within the sac? Like, is it given to the mother or directly under USG guidance into the sac?
No, I feel better to give it when you are going to give it for the pregnancy. Better to give it intra sac. I mean the into the sac, intramuscular giving. I have actually honestly we have not tried this for in our unit. Only those who would have tried, I would ask them to please speak out because I am not so in favor of methotrexate for cesarean scar pregnancy. Anyone else would have tried, please you can tell me. But I would prefer, if at all I want to give, by ultrasound guided into the sac itself.
Right, sir.
Or else if you want to take some time when the mother wants to decide tomorrow if I want to come back, then you can give her one short course, one course of intramuscular methotrexate and send her, and you can plan that for tomorrow.
Think we've covered all the questions, sir.
Thank you. Thank
This
you,
is a
ma'am.
good note to end the session tonight. So I thank everyone for logging in and being such a ardent audience. And we had almost 150 plus attendees today, sir. So congratulations and wishing you a
Thank
very
you.
happy Guru Purnima, sir.
Happy Godi Purnima to you and to all the members. Thank you, Cesarin ma'am, for being there. Thank you, Arun, for giving us the smooth flow across the and for conducting this.
Welcome, sir.
Thank you.